everybody, I'm Kieran Morrissey. I'm the occupational therapist here at Spear Grand Central.
And I'm Macauley. I'm the a physical therapist here at Spear Grand Central. Kieran and I wanted to do this webinar very specifically to discuss physical therapy, occupational therapy, and why they've been partnered together here at Spear. We work together a lot, we see a lot of very similar conditions, and I think it's important that we discuss how our occupations work together, especially for the good of the individual patient, which is always our primary concern. I'm going to talk a little bit about physical therapy, Kieran's going to talk a little bit about occupational therapy, and then we're going to kind of bring it all together to discuss why we love what we do. So again, my name is Macauley, and I am a physical therapist. Physical therapy, very specifically, it was impressed on me the second that I kind of went to school, is that it's very individually focused. We want to focus on kind of understanding the way that the individual moves and how that's creating either pain, disability, or difficulty in your everyday life. A very, very smart teacher of mine once said, you will never treat a rotator cuff, you'll never treat a low back, you'll never treat a knee. You're always going to treat a person who has so many things going on in their life. We want to make sure that we are understanding how specific impairments are impacting you as the individual, and make sure that the treatment plan that we come up with addresses that need. We try to be as personal and as customizable as possible to understand really the person in front of us. We do that through a number of exercises, manual interventions, dynamic movements, static movements, stretches that really depend on how someone responds to something. We never want someone to leave our office feeling like we haven't gotten to the root cause of what's bringing them in our doors in the first place, because we understand that physical conditions, neurological conditions, anything that you may need PT for, that's the first and foremost thing on our mind. We always want to make sure that we're collaborating with our patients, and this is true across PT and OT. We want to make sure that your needs, your concerns, and your specific ideals for what post-treatment looks like are the end goal. That's always what we're working towards. So this is the question that I basically get asked anytime that I bring up what I do. When should I go see a PT? The simple answer that I will usually give is see a PT when you think you should. We work across a number of different conditions that I'm going to kind of bring up a few examples of, but the difference is really when some level of pain, disability, or difficulty becomes more persistent. You know, I think we've all had that moment where we think, do I have to live with this for the rest of my life? Normally, you know, you fall down, you injure something, you get back up, and a few days later you're back to normal. It's really with the, this doesn't really seem to be going away. That's where we come in to kind of speed up the process and get you back to your normal speed. These are some of the many conditions that we treat. Usually people are more familiar with the more orthopedic side of things. You know, joint pain, muscle strains, coming in after a surgery. But physical therapy also works in a number of different arenas. We can work in neurological care, which is a special interest of mine, sports rehabilitation, which is also an interest of mine, cardiac care, lymphedema management. Really the applications are wide-ranging. But the thing that's always most important to me is making sure that, you know, if something's just not feeling right to you, you come in and we can take a look at how you're performing a specific task, whether that's lifting a heavy box from the ground, whether that's your ergonomic setup. New York very specifically lets people come in without a physician's referral for the first 30 days of treatment for physical therapy. I use that time to take a look at everything that might be going wrong and see if we can get you fixed in those 30 days before we have to send you to see a physician. This is a graphic that I kind of like to bring up. This is very specifically for research that was published in low back pain, but it's where we kind of take patients when we first meet them. The first thing that I want to always understand is, number one, are there any clinical red flags that this is not a straightforward condition? Is there something that we're dealing with that really requires a second set of medical eyes? We work frequently with physicians to make sure that patients are getting the best quality of care. And in that case, the kind of medical management side, we don't recommend physical therapy at that particular moment. We want you to get the best care and then come back to us when we can work a little bit more on specific improvements that are going to get the most bang for our buck. On the right side of the graphic, the self-care management, often people get very nervous when they're injured or not functioning the way they should be. When we find that you have all the tools, all the resources that you need to kind of manage this on your own, we'll usually give you a plan to see how you can work with that individually, and then check back in regularly. So think of this as the chair's too big, the chair's too small. We really want the right spot, which is difficulty that is persistent and you have kind of hard time eliminating, and that's where we step in and make sure that our interventions are targeting the exact place where you are. This is the disability, the pain that is not going away in the time frame that you're really expecting it to be. We're not concerned that there are other factors playing in, like other pathologies that may be contributing. This is where we can really dig in and make sure that you're getting a lot out of physical therapy to make sure that you're getting back to the stuff that you need to be doing. What do those treatment sessions look like? Here at Spear, we usually do hour-long treatment sessions. You're going to be working on a combination of exercises. We will occasionally use manual techniques, but we look at the very specific parameters that we can improve your function in, whether that's your strength, your range of motion, your endurance, your kind of structural alignment, any which way that we can make an impact to reduce that overlying level of disability. There are going to be some times that people come into our office and say, I can bench press 200 pounds at the gym. Why are you having me do a chest press with a 5-pound weight? I want to make sure that whenever I have somebody doing an exercise, it is to reduce the level of pain that they're in and make sure that that range of motion is very specific. So these things might seem easy, but I want them to be smooth. I want them to be pain-free. And again, we always want to keep that patient in mind. My treatment session for someone who came off of a high-level soccer injury is going to be different from somebody who's coming in with some kind of idiopathic knee pain that they don't know how they got it. We want to make sure that we're taking your individual day-to-day into mind when we form those treatment plans. And of course, we always want to make sure that we take your doctor's specific orders into consideration as we're going through this. Very frequently when doctors send us patients, they will have very specific orders they want us to follow. This is a collaborative effort both within our office and with your specific physician. So we want to make sure that that's all being synthesized in our treatment session to get you back to the door. My favorite day is when we discharge patients. I mean, PT is not a forever activity. We want to make sure that you're here when you need to be, and then the second that we get to say goodbye, we always celebrate that day.
So now we're going to dive into the wonderful world of occupational therapy. And just a reminder, I'm Kieran. And so many of you might think that an occupation is what you do for a living. Yes and no. So an occupation is what you do for a living, but it is beyond what you do for work or your job. An occupation is really what you do, how you do it, and most importantly, it's why are you doing it. So as an occupational therapist, I really take a holistic approach to my treatment and how I go about my patients. So I'm number one concerned with why are you here? What is going on and what is preventing you from doing what you want to do, and how is it preventing you from doing it? So I kind of have 5 different ways that I go about my treatment specifically, and this is kind of a broad spectrum of how my profession operates as a whole. So we take a very holistic, individualized look at the person during our first initial evaluation. Based on whatever we find in that evaluation, we tailor cut our treatment plans to that specific person. And there's a couple different ways that we can go about that. So most popular in your outpatient setting is someone is coming in with some injury they either sustained from sports or, say, a car accident, or you have the patient who's coming in with, elbow pain, shoulder pain, either due to work-related or leisure-related activities, or there's just not a reason why it's there, but it's there. So that is the wonderful part about this, in that we have to figure out how this really happened, what's going on, and what are we going to do about it. So the 5 different ways that I go about treatment are as follows. So I'm either looking to create or promote some level of physical activity, establish or restore activity that was there and was now lost, either due to injury or, not as common, a non-use situation. And so there's sometimes when our patients come in at a certain age and they want to stay as physically active as they are, and they might have some concerns that, just due to the natural aging process, that they might lose the ability to do some of the things that they enjoy doing. So in that situation, my treatment plans are really focusing on maintaining that current level of fitness that they have in order for them to be able to carry out their daily lives and leisure activities to the best of their ability. There are some situations where a person is coming in with some injury where they're no longer able to do something the way that they once were, either due to injury or just due to the natural aging process. So that's where we really have to take a look at these specific activities and figure out what is the part of this activity that is difficult for this person or they're unable to do now. So in that situation, based on our findings, we have to modify either the activity or the way that we're engaging with the activity. So one good example is, as we age, we might just naturally be losing our grip strength. And what I found with working with some of these patients is that if you give them a utensil that has some sort of larger handle, it doesn't require them to use as much force to hold on to it, and it makes it easier for them to use whatever utensil it is. I often hear this complaint a lot. People who say, I just have difficult cutting my food, and I just find it hard to hold on to the instrument. So that's just one small example of the many different adaptations and modifications we can make to these activities for people in order for them to be independent. And then lastly, once we get to that certain level, we want to push the boundaries a little bit, and we want to prevent future injury from happening. So a common thing I hear is from my patients, oh, okay, I'm not feeling any more pain, like I think I'm done. They might think that they're done, but there's always an added benefit of continuing through your full plan of care to ensure that, 1, the patient is getting the most out of their therapy, and 2, to prevent future injuries. Okay, so now you're asking yourself, when should my patient see an OT, or when should I see an OT? Just like Macauley said before, you should see an OT or a PT when there's something going on in your life that is preventing you from being completely independent and doing what you enjoy most. It doesn't matter how big or how small the injury is. I work with patients who have sustained very complex fractures and bone breaks, or I have someone who's just dislocated their little finger and they're just working on really being able to make a tight fist. It doesn't matter how large or how small your injury is. If it affects what you do, that is a perfectly good reason to come see me as an occupational therapist. And just to kind of dispel some of the rumors with occupational therapy, OTs do more than just get you back to work. As I said before, we are focused on what you do, how you do, and why you do it. And that expands the scope of your life well beyond your 9-to-5 job. And especially in the outpatient setting, I feel the common misconception is, oh, occupational therapists, they really only do hands, or, hands, wrist, elbow. No, that's not the case. Myself personally, I work with the upper extremity, and then I also treat vestibular. So that is just another area in which I took an interest in, and then I received advanced training, and then I saw a need, and I met that need because for me personally, it was very interesting and the work is very fulfilling. Beyond the upper extremity and vestibular, occupational therapists can work with neurological patients, your stroke patients, your spinal cord injury patients, even Parkinson's patients, patients with multiple sclerosis. And patients can also work with your cardiac patients, your post-COVID patients. And again, if you think that your patient could benefit from occupational therapy, they probably do.
And this really brings together what we want, why we wanted to discuss this topic. If you've heard a lot of kind of overlap between our visions, our goals, that's because they're very well aligned in rehabilitation. SPEAR does an excellent job of partnering PTs and OTs together. We often collaborate on patients. We often work together on the same patients. It just depends on what the best need is. So for example, Kieran does a lot of very creative work with getting people back to tasks with tools and techniques that I haven't seen before. If I have a patient who is very limited in a specific task that I have difficulty recreating, I will often ask for his opinion. I will often send that patient over to his station. It really depends on the person that's in front of us, but we frequently brainstorm ideas. That's why we're in the same office. That's why we kind of chose this profession. It's why we're talking about this topic together. The important thing is you, the patient. Anybody who's coming into our office, coming into our doors, who thinks they may be able to benefit from a more collaborative, more holistic approach, that's why we do what we do.
And also, just to add to that, there are those people out there that could benefit from both of us at the same time. It doesn't have to be, I can only work with a physical therapist versus I can only work with an occupational therapist. Oftentimes, if there's something going on, we can really dive into the problem and figure out, is there one that's more suited for this issue, or are we both equally suited? And if we're both equally suited, is this something that we can attack together at the same time versus, do we just kind of want to delegate this? And I think that's where the really collaborative piece of our professions kind of intersect, is where, for example, Macauley will see one person at the beginning of the day. They'll come right over to me immediately after. I'll go over to Macauley really quick. I'll discuss what he did with him, kind of what he saw during the session, and then, if there's anything that stands out to me, it can help me dynamically modify my plan for that day, just so that I can make the best use of my session for that patient.
And we just wanted to thank you guys so much for tuning in to our little talk. The grand takeaway here, PTs and OTs, we work together for you. That's the most important element of this whole equation. If you have questions, we have offices all over the city. I encourage you to walk in, ask our front desk, ask to speak with a PT, ask to speak with an OT. We're very friendly. We are available very frequently, and we're always interested in getting you back to the stuff that you want to do. And cut.
Hello.
Hello.
So we are going to open up the Q&A. My name is Kathleen. I'm filling in for Kieran to do some of the question and answers. We have some questions, and we look like we just had one that came in. So I can start with the question that just came in. I'm an occupational therapist. The question is, do OTs make house calls? And the answer is absolutely. For SPEAR, we have SPEAR on Call, which is our home care program. It is, there's more information about it on the website, but absolutely our OTs and our PTs both do home care, and many OTs also specialize in home care. So we can help you, or any OT can help you across the country. Shall we answer some of these questions?
I think we should. I'm Macauley, by the way. I'm still here. I just switched from this spot to this spot. It seemed more comfortable.
Changing it up. He let me have the nice chair. Okay. So, okay, good. Our volume is getting better. We love to see that. All right, so we were just talking about this question, so I feel like we'll start with this. What are some common injuries that OT and PT collaborate on? So we'll start with that.
It's a great question, and I think we were talking over the answer, and really it comes down to kind of multi-system conditions. So think something as simple as a pinched nerve in the neck, which then impacts the functioning of the arm and hand. That's something, usually the cervical radiculopathy, the pinched nerve in the neck, is something that you would come to see either PT or OT for. But if there are more specialized kind of tasks that you need more help with after losing function of the hand, arm, shoulder in general, that's usually where we'll collaborate a little bit more. Again, PTs and OTs can both see cervical radiculopathy or a pinched nerve in the neck. But if there is a lot of involvement across conditions or across that one, we'd usually try to collaborate a little bit more.
Yeah, and I think in multiple settings, PTs and OTs treat more neurological conditions like stroke and traumatic brain injury. And those are some areas that we collaborate a lot on as well. And it's not just that OT does the upper body and PT does the lower body, but we each have kind of nuanced skill sets. So for somebody who has just sustained a stroke or just experienced a stroke, they're going to probably have difficulty with certain tasks. And OTs are specialists in kind of doing an activity analysis and breaking down maybe where the disconnect is. And then that information can be shared amongst the OT and PT. The PT can focus a little bit more on maybe the physical demands, and then the OT might be able to focus more on kind of the motor planning and the more fine-tuned skills needed for the activity. All right, so the answer is we can collaborate on basically everything, but those are some examples of things that we really see more so in our clinic that we collaborate on. All right, our next question is why is OT different than PT? Like, why are they two different disciplines or two different practices?
I think that over time we've seen the two practices really start to converge in terms of their philosophy. And it's been interesting working in a setting where we have PTs and OTs working so closely together, because one of the reasons that Kieran and I originally wanted to do this talk is I think there's a lot of overlap in the way that we look at problems, the way that we look at a patient that comes in the door. In general, PT kind of looks at global function. How do you operate as an individual? Can you get up? Can you get dressed? Can you walk down the street? Can you buy groceries? What does your whole day look like? We look at, generally kind of gross motor trends and look to address very specific items in there, to improve the function of the overall human being.
Yeah, and then kind of doubling down on that. So occupational therapy is, just like physical therapy, has been around for over 100 years. And kind of at the beginning, the word occupation, and I'm sure you guys know this from the beautiful presentation, but the word occupation, just as a reiteration, doesn't mean job. It means what are your daily occupations? What are the things that you need to do during the day? What are the things that you want to do during the day? What kind of, essentially it's everything that you do, including sleep. So it's not even just from when you wake up and when you go to bed, it's the whole gamut. So if people are having more difficulty with very, very specific tasks, for example, maybe they just have difficulty dressing or they just have difficulty getting in and out of the shower, that might be something that is more geared towards an occupational therapist who can do an activity analysis and also suggest maybe adaptive equipment. That's another thing that OTs are really into, is adaptive equipment. But again, like Macauley mentioned, as time goes on, Medicare is kind of the head honcho that tells us what we have to do in order to get reimbursed by insurance. And something that Medicare is trending more towards is just overall function. So you're never going to go to a PT anymore and just say, I want my biceps bigger. I don't know if anyone's ever done that, but it really needs to have something to do with a functional limitation. And so that is where OT kind of developed from, and PT is kind of coming along for the functional ride. Would you say that that's kind of fair?
Yeah, I think it's a better philosophy. You know, like you can have the biggest biceps, the biggest quads, which used to be a real focus of early PT, but now people are much more concerned with functional capacity. Yes, you may have the biggest biceps in the world, but can you use it to like lift a bag of groceries from the floor to the table? If your biceps are huge, but you still can't do that, what's the point of all the work that's gone into just strengthening the biceps over and over again? I think that the shift to be, addressing the needs of the individual, it's a much better philosophy, and more PTs are adopting that. It should be the standard at this point. And if you're seeing anyone that's not the standard anymore, I think you should call us.
Yeah, I agree. So yeah, in this setting, we're very much similar in an outpatient orthopedic setting. I see a question that just came in. So can OTs make suggestions for home modifications, assisted devices when they make house calls? And absolutely. That's something that is our bread and butter in OT school, is something called aging in place. And so that's being able to hopefully stay in the home that you are in or want to be in for life, including into the later years. So that might mean there needs to be some modifications to the home or modifications or devices that you use. And that's something that OTs definitely can help out with in a house call or even in the clinic if it's more of an assisted device situation. House call is perfect for home mods. And then I think we had one more. Why would I only need to see a PT or an OT? And I'm just going to really quickly say, if you can see both, that's the best, because you're getting multiple eyes from different backgrounds. Although I just said that we kind of are very similar these days. We both had different nuances in our schooling, and I'm of the mindset of if you can get multiple eyes on something, you're going to get the best care. So I think Spear has a really unique situation as an outpatient clinic that has both PT and OT. And so if your insurance allows you to take advantage of both of them, I say see both of them. And like I'm sure Kieran mentioned, it's not just about hand therapy. These are our functional tools. So OTs became the hand therapists. So it used to be if you wanted hand therapy, you had to see an OT. There's a lot of PTs that are starting to become certified hand therapists as well. So it's less divided than it once was. There's a lot of OTs that are pelvic floor therapists when a lot of them used to be PTs. So there's not a real delineation of it has to be a PT or it has to be an OT for any specific injury. I think it's something that if you have an injury and you want to be assessed by both PT and OT, I would take advantage of that because there could be something done differently from both perspectives.
And I think that we'll be the first ones to say if you've been funneled into one camp where we think that you should have a conversation with OT. I think I'm a big believer in there's no place for pride in rehabilitation because it's not about us here, it's about you. I have had a number of patients who've come to me and I said, look, I've seen elements of this condition before, but this with pelvic, you're good to stay on my caseload. I'm here to help you, but let's get a second set of eyes on this because really at the end of when you call up, our front desk staff are more than happy to help kind of figure out generally, should you be making an appointment with OT? Should you be making an appointment with PT? But once that decision's made, it's not set in stone. We talk to each other all the time and we often collaborate on these cases.
Yeah, and just to kind of round that out, if you are coming in to see us and you find yourself, thinking you're going to PT, but you're on an OT caseload, just ask questions. Our OTs are more than happy to explain kind of what our role is. I know it's confusing, and the name occupational therapy just makes people think that we find them jobs or return to work, and it's so much more than that. So ask questions, and know that you can see OT for any body part and you can see PT for hand therapy, and it goes both ways. So if you find yourself on an occupational therapist schedule, I challenge you to ask them more questions about it because they'll have probably other interesting ways of explaining it as well. All right. Well, I think that's all unless there's any more questions coming in. I haven't seen any come in. But like we always say you can find more information on all of this on the website too. We have a whole subsection of occupational therapy for more like videos and information if you're curious. All right.
Bye, guys.
Bye.